So our topic today is acid-base balance. Here are the learning objectives that we will review. Number one, to identify primary acid-base disorders using values obtained by arterial blood gas. To list the most common causes of acid-base disorders. And then finally describe mechanisms of compensation and interpret acid-base disorders with compensation. And you'll see that in these slides as well as the case discussion that we'll review at the end. Here's the outline. We'll just start with some basic definitions. I may speed through these since this is probably familiar to you from some of your undergrad or medical school studies. And then we'll spend more time on primary acid-base disorders, going through the four major disorders, talk about compensation, and then move on to review using the case discussion that we sent. So just to start, acid-base balance, as you know, is about stabilizing the concentration of hydrogen ions in the body. Major things can happen, many of which are bad if that hydrogen ion concentration is out of balance. The concentration in body fluids is small, and so the body works very hard to keep that concentration in a very narrow range. pH, as you know, is what we measure or report to describe hydrogen ion concentration, and the normal pH is 7.4. That's measured by looking at the quantity of hydrogen ions per liter of blood and reported most commonly as 7.4 for normal pH or 40 for the hydrogen ion concentration. Do you know it's a logarithmic scale? So for a normal pH in 7.4, the amount of change in hydrogen ion concentration from 7.4 to 7.3 is relatively small compared to the change in hydrogen ion concentration from 7.1 to 7.0, for example. So the number of hydrogen ions that are changing in the blood is significantly higher at the extreme end of pH because of the relationship between hydrogen ion concentration and pH. Just to set some other definitions, an acid is a substance that gives off hydrogen ions, and a base is a substance which accepts hydrogen ions. So very simple terms here, but of course becomes very important as we talk about balance of hydrogen ions between acidosis and alkalosis. With our next definitions, acidosis is the production of more than normal hydrogen or too little base. So that's the process. And then acidemia is the state of blood pH less than 7.35. Alkalosis is the opposite. So it's the production of less than normal hydrogen ion or having too much base. And alkalemia is the state of having a blood pH of greater than 7.45. The most important system to know about when it comes to acid-base balance is the bicarbonate buffering system. So thinking back to your biochemistry or organic chemistry days, you may remember an equation like this. You have an acid, a carbonic acid in the middle, and it can give off hydrogen ions, or it can convert into water and carbon dioxide. And this is the process that the body goes through different mechanisms to balance the concentration of hydrogen ions in the blood. So just basic review, as you would expect, this is the state of the body in complete balance. So the pH is 7.40. There's an appropriate amount of carbon dioxide and hydrogen ion and bicarbonates. If the body wants to get rid of carbon dioxide, which is controlled by the lungs, obviously, or if it wants to adjust the concentration of bicarbonate, which is controlled by the kidneys, that's going to have an effect on pH. pH reflects one part of this continuum, which is the hydrogen ion concentration, but it really shows the relationship between bicarbonate in carbon dioxide, which is what the body uses to adjust. So when it comes to acid-base disorders, there are two primary categories that we think about. Respiratory, which is related to CO2 levels, which is on the left side of the balance equation, and metabolic, which is related to bicarbonate levels, which was on the right side of that balance equation. The body does use other buffering systems. Hemoglobin buffering system uses hemoglobin to combine with hydrogen ions and affect the pH. There's a protein buffering system occurring within cells, which accounts for a great number or a large amount of acid-base balance, but not something that we measure directly. Phosphate and bicarbonate, as we've already talked, are other systems that are important. So move on to talk about primary acid-base disorders. The first topic will be respiratory acidosis. We'll move on to respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. I'll spend a little bit of time on each of these since it's important as a foundation to understand how these come about and how they're modulated. The first category will be primary respiratory acidosis, something that I'm sure you're familiar with and something that we encounter on a regular basis as anesthesiologists. Decreased minute ventilation causes increased blood carbon dioxide level, which decreases the pH. And the basic equation here is increase in PCO2, which is the partial pressure of carbon dioxide, leads to an increase in hydrogen ion concentration and a decrease in pH. You probably know the equation for minute ventilation, which is tidal volume times respiratory rate. Either a change in either of those values would affect minute ventilation and could cause respiratory acidosis. If you think back to the equation from before, an increase in PCO2 levels leads to an increase in hydrogen ion concentration because bicarbonate is removed at a constant rate, leaving hydrogen ions left behind. So that equation that we saw previously, the hydrogen ion concentration will increase, which decreases the pH. Causes of respiratory acidosis, I want you to think about a few of what those might be. We'll discuss these more during the case-based discussion towards the end, but I'll just review some major categories here with you. Respiratory depression is probably one that we're most familiar with or encounter most commonly around the operating room. So decreased respiratory rate could be from drug overdose. It could also be from head trauma, stroke, or tumor. We think about minute ventilation, tidal volume would be another value that we could change or that might change and lead to respiratory acidosis. And that comes from various forms of neuromuscular restriction. So a patient who has severe scoliosis, rib fractures, inhibiting their ability to generate adequate tidal volumes, neuromuscular disorders like myasthenia gravis or polio or tetanus, or other types of toxicity may have decreased tidal volume leading to respiratory acidosis. And then another category would be primary pulmonary disease. So not something that affects the rate of breathing or the amount of tidal volume, but a problem with the lungs itself. And this could cause decreased tidal volume or increased volume distribution. Primary pulmonary diseases can include COPD, asthma, laryngospasm, pneumonia, ARDS. All of these things will affect your tidal volume, respiratory rate, and ultimately your pH and presence of acidosis. And the endpoint of all of these causes is an increase in blood CO2 level. A few notes about respiratory acidosis: elevated carbon dioxide and low pH can cause catecholamine release. So you can think of patients in whom this would be particularly damaging, patients with hypertension at baseline, patients with arrhythmias, patients with coronary artery disease. If it's an acute problem, your treatment will be to hyperventilate the patient while you address the primary cause. If it's an opioid overdose, you may be treating that. If it is a primary pulmonary issue, you may be providing some other means of supporting respiratory status until that problem resolves. We'll review this more in the end of the lecture, but if respiratory acidosis becomes chronic, like in COPD, the body should retain bicarbonate to help balance that out and restore a normal pH. And we'll talk about more later about what that looks like. Next primary condition that we'll go over is respiratory alkalosis. So increased minute ventilation, the opposite of what we talked about before, causes decreased blood CO2, which increases blood pH. And you can see how all those are related. Causes of respiratory alkalosis, think of some if you can. And then I'll go over a short list here. Decreased blood carbon dioxide could come from hyperventilation, so increased respiratory rate. It could be a secondary cause, so caused by hypoxemia, triggering hyperventilation from any of those causes. Sometimes see it from anxiety or pain. It's obviously can be an iatrogenic cause and something that we need to be aware of by monitoring in-tidal CO2 concentration, or if we don't have that available, paying close attention to what we would expect the respiratory rate and tidal volume for our patient should be. Respiratory alkalosis or hyperventilation could also be caused by certain tumors or trauma, could be caused by infection, and a natural cause of hyperventilation is pregnancy, resulting in a state of respiratory alkalosis. But the end result of all of these being decreased blood carbon dioxide. A few notes about respiratory alkalosis: low carbon dioxide and elevated pH can, as I said, occurs due to hyperventilation. This can cause cerebral vasoconstriction. You think about that with neuroanesthesia and affecting intracranial pressure, can lead to seizures or confusion, lead to other metabolic disorders. If it's an acute problem, you can hypoventilate the patient and figure out what the cause of hyperventilation is and treat that appropriately. If it is a chronic problem, the body should retain hydrogen ions over time. Move on to metabolic causes of acid-base disorders. The first one is metabolic acidosis. Again, something that we encounter frequently in the intensive care unit and the operating room. So we need to be well versed in how to diagnose and to treat it. Metabolic acidosis means there's an excess acid from some source, bringing more hydrogen ion into the system, or in some cases, a loss of bicarbonate. So increased hydrogen ions or loss of bicarbonate leads to a decrease in pH. This will come up in more later. There are multiple metabolic substances that can affect pH balance, and we try to quantify that through the anion gap. And you see the anion gap there. As we work through analyzing blood gases, we'll come back to the anion gap, which is an important part of determining the cause of a metabolic acidosis. So metabolic acidosis causes, unfortunately, there's a long list of these. There are some mnemonics out there that are helpful to help remember what they are. So I encourage you all to be familiar with the major causes of both high elevated anion gap and non-gap acidoses. Here's a list here, and as you review this lecture later or look in textbooks, you can come back to them. High anion gap, the major ones that we would encounter or think about, number one would be lactic acid. So any state of inadequate oxygen perfusion or delivery can cause a lactic acidosis, leading to a high anion gap. Uremia, renal failure, the failure of the kidneys to get rid of hydrogen ions can elevate the hydrogen ion concentration and cause acidosis. Ketoacidosis, there are different forms. The most common might be diabetic ketoacidosis, and then some other causes that would be less commonly encountered, but we should be familiar with. The other major category of metabolic acidosis is normal gap, and the most important causes of these would be bicarbonate loss, so especially from the GI tract, where a lot of bicarbonate could be lost from diarrhea or an ileostomy placement. Acid loads, so either iatrogenic or other causes of acid being pumped into the system. Dilution of bicarbonate with saline. Normal saline can cause a metabolic acidosis, which would be hyperchloremic. And then renal defects, where kidneys are not retaining bicarbonate as they should, can also cause a normal gap metabolic acidosis, with the end result being elevated hydrogen ions or decreased bicarbonate. A couple of notes on metabolic acidosis. As you're aware, treating patients with severe forms of shock, metabolic acidosis is associated with decreased systemic vascular resistance, decreased cardiac contractility and cardiac output, pulmonary hypertension, arrhythmias, hyperkalemia, and it can be a major cause of death in patients. The management obviously includes treating the primary process, and we'll talk about adding sodium bicarbonate later, but it's not infrequent to try to correct the acidosis temporarily with sodium bicarb to help prevent some of those consequences listed there. It should be done cautiously. If bicarbonate is administered, it will eventually be converted to carbon dioxide, and the carbon dioxide level can be elevated if the patient is unable to increase their minute ventilation appropriately. Here's a replacement formula. You may write this down or look it up later to help give you an idea of how much sodium bicarbonate to replace for a patient who has a elevated base deficit or is in a state of acidosis. The final primary metabolic or the final primary acid-base disorder we'll look at is metabolic alkalosis, which implies a loss of an acid or too much bicarbonate, leading to an increase in pH. We'll go through a few causes of that. Primary ones that we might see either in the emergency department, the medical ward, which can result in consequences for us in the operating room, are loss of acids, so either through vomiting or NG suction. If you recall, gastric fluid is high in hydrogen ions, and if those are lost and not replaced, that could cause alkalosis. Diuretics can also cause alkalosis, so causes of metabolic alkalosis. A couple of notes about this. Severe alkalemia can result in seizures or neurologic depression. It's rare, but occasionally you might see patients require dilute hydrochloric acid to correct pH. I'm not going to go through this with you all so that we can get to our case discussion, but this is something to review on your own later. This hopefully is automatic for you thinking about these primary disorders. And we'll cover these questions in our case discussion here a little bit later. Final topic I want to go over is compensation. So compensatory mechanisms counter the primary problem and are part of the body's effort to restore a normal pH in the state of acid-base imbalance. As mentioned previously, this can be accomplished by the lungs. And regulation of changes in pH is triggered in the carotid bodies and has a reflex in the medulla. This can take place rapidly for the body to use the lungs, either hypo or hyperventilation. to correct the alkalotic or acidemic state. The other compensatory process is through the kidneys, through the medullary filtration system. This process is much slower and can take place over days, but does occur and be something that you can see in patients that you're caring for. A couple of rules about compensation. Number one, compensation opposes the primary process with the alternative organ system. Should be straightforward to understand, but the lungs compensate a metabolic abnormality and the kidneys compensate a respiratory. All right, so we'll go back to compensation. So the number one rule about opposing the primary process and using the alternative organ system. And the second rule being that compensation cannot overcorrect the primary process, which is a clue to understanding and analyzing a blood gas. Respiratory compensation, so as you'd assume, the lungs can either breathe off more or less carbon dioxide in response to too or too much, too or too little hydrogen ion or bicarbonate. They can hyperventilate to blow off more CO2, which requires more conversion of hydrogen and bicarbonate to CO2 to balance that. And this equation that we looked at previously just shows that as bicarbonate decreases in a state of metabolic acidosis and relative elevation in hydrogen ion concentration by some of the causes that we looked at previously, that acidosis is resulted, but the lungs can help to compensate for that by hyperventilating and decreasing CO2, which allows the body to restore a more normal pH by shifting CO2 from bicarbonate and then shifting hydrogen and ions over to replace that and bringing the pH back into a normal range. Respiratory compensation can occur in the opposite way through hypoventilation. And I think you'll understand how that works. Metabolic compensation occurs, as said, through the kidneys, which can either retain more or less bicarbonate in response to too much or too little PCO2. Kidneys can retain more bicarbonate, which allows for more hydrogen ions to be removed and balance restored. So same equation as before, except in this instance, you may have an elevated PCO2, which should be caused by hypoventilation, causing a respiratory acidosis. The compensation for this, or the causes are listed here, but the compensation will take place in the kidneys utilizing bicarbonates. As bicarbonate is retained, then the pH can be restored back to normal, balancing out the elevation in carbon dioxide. The opposite is true as well. There are formulas that you can use to predict the expected change of the compensatory response. And I'll divide these up into three major categories. One is respiratory acidosis. The other is respiratory alkalosis. Both of those could be acute or chronic compensation. And then metabolic acidosis and metabolic alkalosis. Excuse me. The most helpful formulas to remember are that for an elevation in bicarbonate from elevation in PCO2 from respiratory acidosis, compensatory response by bicarbonate would be expected to be 1 milliequivalent of bicarbonate for every 10 millimeters of mercury increase in concentration of CO2. We'll go through some examples in our case discussion to help illustrate that. So for acute respiratory acidosis, your expected change in bicarbonate in response to that will be 1 milliequivalent for every 10. You'll see a range, 8 to 10 millimeters of mercury increase in PaCO2. The opposite is true in respiratory alkalosis with a slightly higher change in bicarbonate expected for a 10 millimeter of mercury decrease in PaCO2. Of course, metabolic acidosis is a disorder of bicarbonate, primarily from excess acid or inadequate bicarbonate, and the compensatory response is in CO2. If metabolic acidosis is the primary issue, the compensatory response for CO2 levels will be 1.2 times the decrease in bicarbonate from baseline. The opposite, so a compensation for metabolic alkalosis, would be an increase in PaCO2, and the formula for that is 0.7 times the increase in bicarbonate from baseline. We'll skip through this and you can visit that later. And now that we have about 25 minutes left, I'd like for us to work through our case discussion, which hopefully you received beforehand. All right, so this is a case that hopefully you were able to review beforehand. I'll go ahead and read it and then ask our first question. And I'm just going to go off of the names that we have on the list here. A 63-year-old, 110 kilo male with a past medical history of hypertension, CHF, COPD, obstructive sleep apnea, and diabetes, presents to the emergency department with nausea, vomiting, and severe abdominal pain. He is febrile with a leukocytosis of 17,000. He is found to have an incarcerated abdominal wall hernia with concern for bowel strangulation, and the decision is made to proceed to surgery. His initial hematocrit is 40, hemoglobin around 11 to 12. Vital signs are seen there with a saturation of 95% on room air and a respiratory rate of 16. As part of the preoperative labs, an arterial blood gas is drawn and shows the following: pH 7.39, PCO2 of 52, bicarbonate of 29. Great, so the big table there at Bahardar. Can I have whoever's sitting closest tell me something about this patient's acid-base disturbance?
The patient has acid-base disorder. Most likely it's respiratory acidosis with pH less than 7.4 and partial pressure of carbon dioxide, which is greater than the normal, which is 45. And there is a composition increment in bicarbonate, which is above the normal, which is 29, but the normal is between 24 to 26. But I didn't calculate whether the composition is appropriate or not in order to tell whether it's acute or not chronic.
That's perfect. You know, the only thing I would mention is that the pH is actually normal. You know, there is a small range around 7.0, 7.40 that we would consider normal or close to normal. So you're right. This is a respiratory acidosis that's compensated. Would you suspect this to be an acute or chronic compensation?
It looks like chronic.
Okay. What indicates that to you?
HCO2 is increased by 12, and HCO2, bicarbonate is increased by 3. Like the compensation for chronic respiratory acidosis is 4. It's comparable.
Very good. And what in this patient's history would suggest a cause of this respiratory acidosis, this chronic respiratory acidosis?
She has chronic conditions like COPD and obstructive sleep apnea, which may dispose her for hypoventilation and respiratory acidosis.
Okay, fantastic. Very good. Move on to our next question. The patient is taken to the operating theater, induced with fentanyl, propofol, and a non-depolarizing neuromuscular blocker, and mechanical ventilation with a control mode is initiated. So for this patient, as described, what would appropriate initial ventilator settings be? how does his underlying acid-base status affect your ventilator goals and target PaCO2?
Yes, so this patient has acidosis, so initially we have to increase the respiratory rate from the mechanical ventilator, and we should also target our normal mid ventilation for the patient. And our target CO2 should be, internal CO2 should be in the range of 35 to 45. And CO2 also almost similar with 5 difference from the internal CO2. And that's my answer.
Good, good. Thank you for that. Yeah, I think that is true for a patient who is in an acidemic state, that you would want to compensate with some slight hyperventilation. However, this patient is compensated. His baseline PCO2 that his body has adapted to is at a higher level. And so because his body has already compensated and adapted to that, correcting that quickly with hyperventilation could lead to an alkalosis. You may suspect that with his underlying disease process, he could become acidemic in other ways, but your initial settings actually would most likely allow his end-tidal CO2 to be slightly higher, assuming that his PaCO2 will be slightly higher, since that is his baseline. For a patient with severe COPD, it may be difficult to hyperventilate anyways. So it's okay in this patient to allow them to be have a slightly elevated PCO2 or a decreased minute ventilation because that's what their body is used to. We'll go on to the next part of the scenario. So the operation proceeds without complication. A small portion of ischemic appearing bowel is resected and anastomosed. During the procedure, the patient receives the fluid mentioned there. The patient's extubated at the end of the procedure. In the recovery room, the patient is slightly agitated. He's having shortness of breath and hypoxia. Oxygen saturations are 88% on 8 liters oxygen, and the patient is placed on a non-rebreather. The exam is notable for crackles at the bilateral lung bases. Vital signs are as follows with the respiratory rate, of 22. A new arterial blood gas is drawn, which shows a pH of 7.27, a PCO2 of 68, and a bicarbonate of 30. Look at that blood gas. What acid-base disturbance is seen here? Well, as I look at it, I would look at the pH first, decide whether that's acidemic or alkalemic. You can see the pH is less than 7.4, which is acidemia. And then look at your PCO2 and your bicarbonate and see what direction those have changed. The PCO2 is elevated, which is a cause of acidosis. So, and the bicarbonate is elevated too, which would be a compensation for that. So the primary disturbance is a respiratory acidosis, which the patient was previously compensated for, but now is not. Thinking about causes of a presentation like this, could someone there in Bahadar give me a couple of potential diagnoses that would cause this?
Maybe the patient has a pulmonary edema with bilateral crackles and effacement or consolidation plus hypoxic with shortness of breath.
Okay, very good. Yeah, you've looked at some of those clinical signs there and made that diagnosis. With his underlying COPD, he may not be able to compensate for pulmonary edema, and that could lead to inadequate respiratory effort, leading to elevation in PCO2 and respiratory acidosis. Excellent. Of course, in the PACU, we're thinking about other causes as well, residual anesthetic effect, opioid overdose that could lead to respiratory depression and respiratory acidosis as well. So imagine that this is you. You're in the PACU evaluating this patient you've just taken care of, what would be some of your next steps clinically to correct the abnormalities that you've diagnosed on this blood gas?
So our management will be to treat the underlying condition for heart deterioration. With if the patient has pulmonary edema, we may give like diuretics, and if the patient has concomitant infection, we may try antibiotics. And then if the acidosis is becoming severe with the pH less than 7.2, we could try the bicarbonate, sodium bicarbonate, with half dose.
Good. I agree with all those. I will say for a respiratory acidosis, you do want to be careful giving bicarbonate to correct the acidosis, especially in a patient who's extubated like this one. If you give bicarbonate, it will get converted to carbon dioxide at some point, and that will need to be exhaled off, or the acidosis may get worse. This patient does have underlying respiratory issues, so giving sodium bicarbonate may help in the short term, but if they're not able to ventilate appropriately, then that could give you issues in the longer term. Okay, so that would be one caveat. Great, we'll move on in this case. So the patient's respiratory status improves and the postoperative course is otherwise uncomplicated until postoperative day 3, when the patient acutely declines. He's febrile. Vital signs are shown there with a respiratory rate of 22 with saturation of 91%. The white count is more elevated than it was previously. You have a basic metabolic profile with a sodium of 139, potassium of 3.2, chloride of 90, CO2 or bicarb of 23, a BUN of 33, creatinine of 1.6, and a glucose of 190. You also measure a lactate, which is 4.1, and you have another arterial blood gas, which shows a pH of 7.29, PCO2 of 50, and a bicarb of 23. Good, so we're getting a little more complicated here. We moved from a compensated respiratory acidosis to an uncompensated respiratory acidosis. And we now have this blood gas, which shows pH of 7.29, CO2 of 50, and a bicarb of 23. Someone want to explain these values for me?
The patient may have a mixed acid-base disorder. As we have seen, patient is deteriorating. Initially, she has a respiratory type of acidosis, but the baseline bicarbonate is decreasing from 30 to 23, which is a decrement in bicarbonate indicating concomitant metabolic acidosis, plus increment in lactate and pH values in acidotic range, and partial pressure of carbon dioxide is decreasing. So from the baseline, maybe compensation or concomitant mixture type of acid base balance disorder.
Good, thank you. So if you think it is a mixed acid-base disorder, you think there's a respiratory component, which you've mentioned, the PCO2 is elevated and the pH is decreased, which you're correct about that. And you suspect that it's mixed and that there may be a metabolic component as well. Could you tell me why you think that when the bicarb is 23, which is approximately normal, correct?
Yeah, it's correct, but it's a decrease from the baseline from 30 to 23, which is significant.
Additionally, they shared elevated lactate.
Good. You're right. So you would expect that bicarb to be elevated to be compensating for this respiratory acidosis. However, it's inappropriately normal. The bicarb should be elevated, but it's not, which means that there's some cause, metabolic, that's causing that bicarb to be lower than it should be, which means that there's a metabolic acidosis going on as well. Very good. Another question for you, is this elevated anion gap or a non-gap acidosis?
It is a high ion gap type of metabolic acidosis with elevated lactate plus a low potassium level, which is a high gap type of metabolic acidosis.
Okay, great. So yeah, use the sodium, the chloride, and the bicarb to calculate your anion gap. And then you're right, the elevated lactate is an important clue to the cause of the acidosis, the presence of elevated lactate leading to a metabolic acidosis. And that is important for us as a clue to the patient's clinical deterioration. Based on the findings of the blood gas and the analysis that you've given, what do you think the most likely underlying cause of the patient's clinical deterioration is?
Maybe she has sepsis with septic shock with hypoperfusion. Okay,
very good. And you can see, in addition to the clinical picture, the vital signs, but also the blood gas helped us to reach that conclusion. This is the question that came up earlier. Is sodium bicarbonate indicated for correcting this patient's acid-base disturbance? All right, I got one raised hand for no. I would say no in this situation. The acid-base disturbance is not severe enough to warrant using sodium bicarbonate. You can provide other treatments for shock, and this patient will need the usual treatments for septic shock, including fluid administration, antibiotic, transfer to a higher acuity setting, possible initiation of vasopressors. But at this point, sodium bicarbonate is not indicated. If the pH was decreased below 7.2, if you are having hemodynamic or arrhythmogenic effects that you cannot otherwise correct, then using sodium bicarbonate to bring the pH into a normal range would be appropriate. Okay. Fortunately, in this case, you provided the appropriate treatment. The patient improved and was discharged from the hospital to home several days later. Very good job.